Okay, let's dive in. Welcome back to the deep dive. Today, we're really cutting right to the core of community health nursing practice.
We really are.
The source material we've been swimming in is Chapter 21, and it's focused entirely on family health risks.
And this truly is foundational work. If you are preparing for real-world community or public health nursing, this understanding of the family it's paramount.
Absolutely.
So our central mission today is recognizing that the family is the crucial aggregate. It's the basic social unit. It's where health values, habits, and all those risk perceptions are developed and modeled.
It's where health happens.
It's where health happens, or frankly, where it fails to happen.
Right, because individual health behaviors don't exist in a vacuum. They're not in a lab. They happen at the dinner table in the living room. So if we really want to move the needle on public health, we have to look at that immediate environment.
Exactly. And this means we, as nurses, have to make a really crucial perspective shift. I mean, historically, public health was so intensely focused on infectious diseases, right?
Right.
Treating the sick individual.
Sure, the germ theory model.
Right. But over the last century, the leading causes of morbidity and mortality have shifted dramatically, at least in developed nations. We're now dealing primarily with chronic conditions, with accidents, and with violence.
And the common thread there is lifestyle.
It's lifestyle, it's behavior, and it's all these complex environmental factors. So understanding and mitigating family health risks is, you could argue, the most direct and efficient way to improve population health outcomes. Period.
So we're not just treating symptoms anymore. It sounds like we're trying to redesign the whole ecosystem that the individual lives in.
That's a great way to put it. We have to assess the family unit within its complex environment, biological, social, economic, all of it.
Okay, so that sounds like a complex system, which means we need to define our terms, our tools before we get started. We're going to be using some specific terminology today. We're talking about risk.
Right, which is just any factor that increases the likelihood of ill health.
And we'll cover family crisis, which is that critical state when, the demands on a family just totally exceed their resources and things start to fall apart.
And then we have the process concepts, the things that define our goals. So health risk appraisal. That's the formal assessment process. You're trying to determine if a risk factor is there and, how big of the deal it is.
And the flip side of that is health risk reduction.
Which is the goal.
Yeah.
Decreasing the number or the magnitude of those risks we've identified.
And then we're going to get into the really specific high-touch nursing strategies later. Things like home visits, which, they offer this unique assessment opportunity you just can't get in a clinic.
You really can't. And all of this is driving toward the ultimate goal of empowerment. It's about shifting that control to the family so they can achieve self-efficacy in their own health decisions.
So our mission today is pretty ambitious.
It is. We're going to take you step by step through this material. We'll start with the historical context, define the systems and models we use to explain risk, and then we'll get into the really detailed, hands-on implementation of nursing interventions. We'll focus heavily on home visits and contracting.
Okay, so let's start at the very beginning. How did we even start formally studying this health-family relationship?
Well, historically, the academic study of family health really took off in the 1970s, and it concentrated on three major areas. First, researchers looked at the dynamic effect of illness on families.
Okay, so how a diagnosis changes everything inside the home.
Exactly. Think about a sudden stroke or a long-term cancer diagnosis. How does that reorganize roles, finances, emotional stability? Someone named Littman back in 1974 really emphasized just how dramatic that reciprocal effect is.
That makes perfect sense. The illness doesn't just happen to the patient, it happens to the entire social unit.
Right. The second focus was the family's role in the cause of disease. So examining family behaviors that increase risk, like smoking norms or poor nutritional habits passed down.
And the third?
The third was the family's role in the use of services. Why do some families readily seek preventative care while others wait until a crisis forces them into the ER?
That's a huge question in public health.
It is. And Mauch, around that same time, made a really key proposal. He said, we have to distinguish clearly between family health, which is the functioning of the unit, and individual health. We have to see the family as its own dynamic system.
And this academic recognition, I assume, led to changes in how governments approach the issue, which brings us to policy.
It does. We define family policy really broadly. It's basically anything done by the government that directly or indirectly affects families. And the quality of a nation's policy really shows how well it understands that central role of the family.
We see this play out dramatically in U.S. health legislation, right? The Affordable Care Act, the ACA, is a huge recent example.
It's a powerful one. Our sources note that, while major disparities still exist, the ACA certainly decreased some health disparities, particularly for low-income families and families of color.
And it did that by mandating coverage for pre-existing conditions, improving access to mental health services.
Right, and eliminating that cost disparity for women's care, and, of course, allowing millions of young adults up to age 26 to stay on their parents' insurance.
That one measure was just transformative for so many people. But I remember all the political pushback. Does the source talk about the predicted negative fallout from some of the policy changes?
It does, absolutely. We have to note the prediction of negative economic effects, especially due to the 2017 elimination of the ACA's individual health insurance mandate.
Because when the mandate goes, the risk pool changes.
The risk pool changes, and that inevitably ripples through the entire system. It affects premiums, coverage, costs, all for the American family. It just highlights the inherent instability in the current policy.
And this is exactly why the nursing role is so vital. It goes so far beyond just clinical care. Nursing has this rich, long history in social activism and advocacy.
Yes, and our sources explicitly call on nurses to continue that tradition, to be key builders of cohesive family policy, a policy that focuses intensely on providing access to primary and preventive care for all families.
Especially vulnerable populations.
Especially. That kind of preventative policy is really the only way to manage large-scale health risks. This focus on prevention is exactly what drove that major shift in our national health objectives.
Right. Once chronic disease, accidents, and violence became the leading threats, the focus had to move from germ theory to, well, human behavior and the environment.
Precisely. And the foundational evidence for this came from that landmark study over 50 years ago now, the Alameda County, California study.
Ah, yes. Bellick and colleagues back in '72. They showed these clear, measurable relationships between decreased morbidity and mortality and sticking to 7 specific lifestyle habits.
And it's just amazing how relevant these 7 habits still are today.
It really is. Sleeping 7 to 8 hours a day, eating breakfast almost every day, rarely eating between meals, maintaining a healthy weight.
Never smoking, rarely drinking alcohol, and getting regular physical activity. Just doing those 7 things substantially decrease the probability of getting sick or dying early.
And that data has been so beautifully supported by more recent work, like Dan Buettner's research on the blue zones.
It really has. Buettner's work on these communities around the world with extreme longevity, it just corroborated the importance of lifestyle, but it broadened it to the whole cultural environment. Yeah. His research gave us the 9 lessons for living longer.
Let's look at how they connect. He talks about lifestyle changes like move naturally, so being active is part of your daily life, not just, hitting the gym.
Right. Or hara-hachi-bu, that Okinawan principle of stopping eating when you're 80% full.
A painless way to cut calories. And having a plant slant, so a mostly plant-based diet.
But what Buettner really emphasizes are the social factors that make those behaviors possible. Things like downshift, so finding routines to shed stress. Or belonging to tribe social circles that actually support healthy behaviors.
And making loved ones first. Prioritizing family, dedicating time and energy to them.
It's fascinating because the Alameda study gave us the behaviors, and the Blue Zones research gave us the social structures that make those behaviors easy and sustainable.
It connects the individual's choices right back to their family and their community norms. I mean, it's hard to smoke if your entire social circle discourages it.
Which is precisely the point of setting national health goals. When you look at the government's objectives in Healthy People 2030, so many of them explicitly address the family environment to decrease risk. Well, specific goals include increasing the proportion of smoke-free homes, increasing homes that have entrances without steps, which addresses accident risk, and reducing the number of families spending more than 30% of their income on housing.
Which is a huge economic stressor.
A massive one. These are all policy objectives targeting that family aggregate. It just proves its central importance.
Okay, so now that we get the historical and policy context, let's look at the motivational and theoretical models that really underpin family health nursing. It all starts with, why people choose health in the first place.
The 2019 update to the health promotion model gives us a really useful framework for that. It says individuals are typically motivated by 2 major and often intertwined factors.
The first factor is the desire to promote health. That's the proactive side, right? Moving towards self-actualization, higher fitness, just overall well-being. It's about striving for a better state.
And the second is the desire to protect health. That's the reactive side. actively decreasing the probability of illness or dysfunction.
Hmm.
So health behaviors serve both this proactive self-actualizing role and a protective role against immediate threats.
And when we talk about family health, how do we define it beyond just a list of healthy individuals?
That's a great question. While definitions vary, using the developmental framework gives us a really powerful and clear operational definition. It says family health is having the collective abilities and resources to accomplish family developmental tasks.
So the successful navigation of those stage-specific tasks, like launching children or integrating aging parents, that becomes the key indicator of whether the family unit is healthy and functional.
Precisely. And that leads us right into systems thinking, which is crucial because the family is nested within so many other systems. If we zoom out and look at the family as a complex system, the Neuman Systems Model gives us the perfect lens to understand its stability.
It really does. The Neumann model defines family health in terms of system stability, and that's characterized by the dynamic interplay of 5 interacting factors: physiological, psychological, sociocultural, developmental, and spiritual.
The family is viewed as this whole system that's just trying to maintain equilibrium. The nurse's role is to use the family's existing strengths and resources to stabilize that system when stress inevitably hits.
So stability is maintained by the system's defenses. You've got the flexible external line of defense, that's the protective outer barrier that's always expanding and contracting.
Based on environmental stressors,
Yeah.
right? And then you have the normal line of defense, which is the family's usual state of wellness.
So stress happens when a major life event is powerful enough to contract that flexible line and break through the normal line of defense.
And that can lead to family disorganization. The Neumann model is strongly wellness-oriented. The goal is prevention, to both reduce the probability of encountering a stressor and, critically, to strengthen that flexible line of defense through health promotion.
Let's apply this clinically, like the source does with the Harris family case. So you have Mrs. Harris and her children, 12-year-old Kevin, 8-year-old Leisha, and the 75-year-old grandmother, Betty. And Kevin was just diagnosed with type 2 diabetes. That diagnosis is the huge stressor hitting the system.
A perfect scenario to use the 5 variables. First, you assess them physiologically. Are they physically able to deal with Kevin's illness? Does Ms. Harris have other health issues that limit her caregiving? Is grandmother Betty mobile enough to help out?
Then psychologically, how stable are their relationships? Do they communicate well? Are there, memories of other family members who struggled severely with diabetes that might cause panic or denial? You need to know the emotional history tied to that diagnosis.
Third, socioculturally.
Mhm.
How will their cultural norms influence treatment adherence? Do they have enough social support? A church group, a tight-knit community? Is the prescribed diet culturally sensitive, or does it clash with their traditional meals, making it almost impossible to stick to?
Fourth, developmentally. How does this diagnosis affect Kevin's pre-adolescent stage? Is he old enough to understand carb counting? And how does it affect the family's overall stage of development? Has this major chronic illness burden just been dropped on them while they're trying to master other tasks?
And finally, spiritually. This can be a huge variable. How do the family's spiritual beliefs affect their willingness to adhere to therapy? Do they believe in medical intervention, or do they rely more heavily on faith healing?
So by assessing all 5 at once, the nurse gets this holistic view of the family's total capacity to adapt and stabilize their system.
Exactly. It allows for truly holistic care.
That makes the Neumann model a really foundational assessment tool. Now let's move from system stability to the risks that threaten it. We talked about the 3 general categories of health risks: inherited, biological, age-related, environmental, and behavioral.
And while identifying a single risk is important, the critical public health concept here is accumulated or synergistic risks. The combined effect of multiple risks is often significantly greater than just the sum of the individual effects. They multiply rather than just adding up.
Can you give us a clear illustration of that synergy?
Certainly. Let's think about cardiovascular disease, CVD. A biological risk might be a family history of early onset CVD. Now you add smoking, a behavioral risk, that's bad, but then you pile on a poor diet and a lack of exercise, which are influenced by both family norms and the community environment.
So if they live in a food desert and in a family where smoking is just normal.
The biological risk is exponentially amplified. Precisely.
I see. So a supportive community environment can actually act as a buffer against some of those other risks.
It absolutely can. The sources give a compelling comparison. Communities in the Northwest have historically been more supportive of exercise programs, healthy eating, and outdoor activity, compared to some regions in the Midwest or the South where traditionally you have a more sedentary culture and these heavy, rich diets.
So when biological risk combines with negative family norms and a non-supportive community environment,
The combined detrimental effect is massive. So intervening at the community level, supporting bike paths, advocating for healthy food availability, that's a highly effective way to reduce the synergistic effect of these health risks.
so once we identify these potential risks, the next clinical step is appraisal. Health risk appraisal, or HRA. That's the systematic process of assessing for these factors.
Right, this can be done with specialized computer software or formal paper instruments, but the core approach is the same. You determine if a risk factor is present, you quantify its magnitude, and you calculate the total burden. A great public example is the CDC's Youth Risk Behavior Surveillance System, the YRBSS.
And that monitors key health risk behaviors among youth, like obesity and asthma.
Exactly. The appraisal method weights those factors to drive a total score, which lets the nurse examine the risk across the entire family unit, not just the individual.
And the ultimate clinical goal then is health risk reduction. The assumption that if you decrease the number or magnitude of risks, you decrease the probability of something bad happening.
Right. Interventions could be as formal as a family contract about drug use, or as simple as parents committing to not drinking and making sure alcohol isn't readily available in the home.
But we also have to consider the family's internal dynamics, specifically their tolerance of risk. Our sources cite that voluntarily assumed risks, like choosing to overeat or drive fast, are generally tolerated better than risks imposed by others, like workplace pollution.
Yes, and similarly, natural risks like floods or hurricanes are often seen as less psychologically threatening than human-created ones, like chemical pollution or a neighborhood crime wave.
Huh.
So our risk reduction strategies have to align with how the family perceives and tolerates that specific risk, otherwise compliance is going to be minimal.
Sometimes, though, the accumulated demands just exceed everything. That's when you hit a family crisis.
This is when the family just isn't able to cope with an event and they become disorganized, dysfunctional, or destabilized.
And this is a critical distinction for nurses, right? We have to differentiate between resources and coping strategies.
It's an essential distinction. A crisis exists when the demands exceed the family's resources. Those are the tangible assets, like money, social support contacts, extended family nearby, but they also lack adequate family coping strategies, which are the processes and behaviors they use to adapt.
So the resource is the financial capacity of the relative.
And the coping strategy is the family's ability to actually have the difficult conversation and ask for that help without shame.
So if they have the resource but they lack the strategy, the crisis is likely to happen anyway.
Precisely. That distinction is essential for the nurse when planning interventions. You address lack of resources with referrals, but you address a lack of coping strategies with teaching and contracting.
Okay, let's pivot now and break down those three major risk categories in more detail and talk about the indispensable tools nurses use to assess them. We'll start with A, biological and age-related risks.
These risks involve conditions that are associated with genetics and lifestyle, so cardiovascular disease, type 2 diabetes, obesity patterns, certain cancers. And our sources emphasize the perennial difficulty here, separating the pure biological risk, the genetic predisposition, from the family lifestyle factors that ultimately determine if the disease even shows up.
So for a genetic predisposition to hypertension, the family's environment, their diet, their activity levels, their stress management, that becomes the primary mitigating factor.
Absolutely. We also have to intensely focus on transitions. These are times of heightened risk when families move from one life stage or condition to another, and we categorize them into two types, normative and non-normative.
Normative events are the anticipated ones, the predictable milestones like the birth of a child, a kid going off to college, or the eventual death of a grandparent. And because they're anticipated, they require anticipatory preparation.
That preparation is key. Families need to learn new skills, make financial decisions, reallocate roles. Successful anticipatory preparation, which the nurse can facilitate through health teaching, drastically increases their coping ability and decreases the chance that the transition becomes a crisis.
And then you have the non-normative events,
Like curveballs.
the unexpected events, a major illness, sudden job loss, divorce, or even a sudden unexpected positive change like winning the lottery.
And because families have little or no time to prepare for these, they often result in acute increased stress, which can lead directly to crisis or family dysfunction. The nurse has to intervene faster and focus immediately on shoring up resources and coping strategies in those situations.
To structure the assessment of these normative life stages and predict those transition risks, nurses rely on the family life cycle stages framework.
This framework is basically a map. It organizes all those normative events into stages and identifies the key transition points and the developmental tasks the family has to master. For instance, the launching stage requires the single young adult to establish their career, manage finances, and develop mature relationships outside the family.
Or consider the families with young children stage. The tasks are immense. Integrating the children, adjusting parental roles, who does what, and mastering new financial demands like childcare.
And as the family matures, you move to families in later life tasks. That includes maintaining function and interest in later life and establishing the role of the middle generation as supporters, not managers, of their aging parents. Using this framework ensures the nurse focuses on stage-specific stressors and the skills the family needs.
And to comprehensively assess biological and generational risk across these life cycle stages, nurses rely so heavily on the genogram. This is the quintessential nursing assessment tool.
It is. It's a detailed three-generation drawing that uses standardized symbols. We need to be able to read this quickly. Squares are for males, circles for females, an X through either means a death, and solid horizontal lines represent marriage.
With vertical lines connecting parents to their kids, and crucially, dates of birth, death, and major illnesses like cancer, hypertension, mental health conditions are listed for every single member.
Exactly.
So what's the real utility here? Why is a genogram better than just asking for a medical history?
Because it forces a systemic view and it drives a deeper interview. Its nursing utility is immediate. It lets the nurse quickly identify patterns of chronic conditions that may run in the family. If the Graham family's genogram shows hypertension and type 2 diabetes in every generation on the maternal line, that is immediate evidence for high biological risk.
And a clear target for primary prevention.
A very clear target. By developing a family chronology and plotting relationships, the genogram becomes a focused guide for an in-depth health interview. It helps the nurse ask about the context of the disease, not just the disease itself.
That brings us to B, environmental risks. We have to recognize the massive impact of the external world. These risks include social, economic, and physical factors. Social risks cover everything from living in high-crime neighborhoods to having inadequate recreation or health resources nearby.
And we must explicitly include discrimination, whether it's racial, cultural, or aimed at non-traditional families like same-sex parents, as a major social risk factor. The psychological burden from chronic discrimination or fear is, in itself, a stressor that accumulates and compounds every other risk.
The most critical external predictor of health is economic risk. This is the relationship between a family's financial resources and the collective demands placed on them. Their ability to purchase necessary goods, housing, food, education, healthcare is just fundamental.
And this is where policy creates that unfortunate gap in the U.S. system. Families at the poverty level usually qualify for public assistance, like Medicaid or WIC. Upper-income families afford comprehensive private insurance. But so many middle-income families have jobs without health benefits, yet they earn just enough to be disqualified from public assistance.
They fall into an economic gap that leaves them highly vulnerable to crisis if something unexpected happens.
It creates a massive strain. And the nurse, in this scenario, plays a dual role, not just providing care, but acting as a resource navigator.
Right.
It's a critical role. The nurse has to teach families about the government resources available, Medicaid, WIC, TNF, SHE-SPE, and provide clear, practical directions on eligibility and how to apply. We know WIC, for instance, is proven to be important not just for nutrition, but for linking low-income families to the larger preventative healthcare system.
So when you're assessing all these external environmental and social risks, you use the second key drawing tool, the ecomap. While the genogram shows internal family history, the ecomap represents the family's interactions with the outside world.
Their entire ecosystem. Think of it visually. The family is the central circle, and key outside organizations, work, school, church, close friends, healthcare systems are surrounding circles. The lines drawn between the family and those external systems are what tell the story.
And the quality of those lines is crucial, right?
It's everything. Solid lines mean strong, beneficial connections. Dotted lines mean tenuous or weak connections. And the jagged zigzag lines indicate highly stressful or destructive relationships. Arrowheads on those lines show the flow of energy.
Is the outside system giving support into the family, or is the family's energy being drained out by it?
Exactly. The utility of the ecomap is immediately clear for planning interventions. If the Graham family's ecomap shows a zigzag line between the parents and work, and the arrow points out of the family, that signifies work is a major source of stress. It demands an intervention.
Like a stress management teaching or a referral to occupational health resources.
It also helps the nurse assess community characteristics. Neighborhood safety, the family's origin, how long they've lived there. The ecomap helps you see if the family is isolated or if they have a rich support network, and that informs how intensive your intervention needs to be.
Finally, let's look at C, behavioral lifestyle risks. This is where the family environment truly dictates health outcomes.
It really is. The family unit is the basic determinant of lifestyle. They decide what food is purchased and prepared, they set sleep patterns, they monitor social norms around substance use, and they decide when it's appropriate to seek care.
And given that two of the major causes of death, heart disease, and cancer are directly linked to diet, the family unit's choices are just crucial.
It extends to activity, too. Regular physical activity is proven to prevent colon cancer, stroke, manage diabetes, strengthen bones. The family structure, whether they prioritize shared activities and the availability of community support, like safe parks and paths, are integral to helping them choose activity over being sedentary.
We also have to address substance use, a major behavioral contributor to morbidity and mortality. Nurses have to educate families about smoking cessation, but also about the risks of passive or secondhand smoke, especially for kids.
Linking it to conditions like cancer, SIDs, and low birth weight. And of course, the abuse of illicit drugs and alcohol is associated with violence, HIV transmission, fetal alcohol syndrome. The research specifically identifies family factors that decrease this risk in kids: family closeness, shared activities, and consistent positive role modeling.
A family is the protective factor.
It can be.
Then there's the sensitive, painful issue of violence and abuse. This is so widely underestimated because it's hard to collect accurate data. It's often hidden.
And because violent is often intergenerational, abusers were frequently abused as children, the nurse's role has to be one of intense, watchful observation. You need to focus on nonverbal cues, subtle signs of injury, and what is not said, rather than just waiting for the client to bring it up. They rarely do.
That brings us back to how families process risk messages. If a nurse gives a clear warning about smoking or diet, why do families so often ignore it or reformulate the message?
There's some valuable evidence-based research on this. The ERNIE study, which involved low-income rural families, explored how they process new, scary information. They identified a core process called reforming the risk message.
Reforming the risk message.
It occurs in 3 phases. Visiting my perception, so acknowledging the family's current view, weighing the evidence, evaluating the nurse's info against their own life experiences, and then making a new meaning. Forming a new, sometimes safer, interpretation.
That's powerful because it shows that nurses can't just deliver information and expect compliance. You have to explore why they're reforming the message.
Exactly. If the family's new meaning still includes the risk, say they believe a little bit of pollution is okay because we can't afford to move, the nurse has to understand that belief structure to tailor the intervention.
So a formal behavioral risk assessment has to focus on several dimensions: the value they place on the behavior, their knowledge, the barriers they face, the benefits. You have to understand their perspective completely before you can intervene.
You really do.
Okay, now we're going to transition from assessment to the hands-on methods nurses use to reduce these risks. Starting with the signature intervention of community health nursing, A, home visits.
The value of the home visit just cannot be overstated. Its purpose is clear. It allows for a far more accurate assessment of family structure, the natural home environment, and actual behavior than any clinic visit ever could.
You can immediately identify physical barriers like trip hazards or lack of safe food storage and supports.
And you can modify interventions instantly based on the family's real-world resources. The data shows the long-term effects are overwhelmingly positive and often prove cost-effective for society.
So the advantages are immense: client convenience, a comfortable setting, individualization. But you mentioned cost earlier. That's the primary disadvantage, right?
It is. The preparation time, the travel, the time spent with just one client, the follow-up. It makes the home visit inherently expensive per client hour. So agencies have to prioritize which high-risk families benefit the most to ensure the maximum societal benefit.
And the home visit requires systematic planning. It's structured into 5 phases. The first is the initiation phase.
This is usually triggered by a referral. The nurse has to clarify the source and the purpose of the visit, and that understanding has to be mutual and shared with the family right from the start.
The second is the crucial previsit phase. This involves that initial contact, a brief phone call, no more than 15 minutes, to establish a shared purpose, determine their willingness to participate, and confirm a time when most members can be present.
A key practical challenge here is refusal. What happens if the family says no?
Right.
The nurse has to explore their reasons. It might be due to fear or misunderstanding or embarrassment, not outright rejection. If a family says no, the nurse needs to renegotiate the purpose or offer a different venue. It's about respecting their autonomy.
The previsit phase also involves practical issues, like safety.
Absolutely. The nurse has to examine both personal fears and objective threats. Agencies have to provide safety protocols, required escorts for certain areas, mandated sign-out processes detailing where the nurse is going and when they expect to be back. And of course, today's practice requires adhering to infectious disease precautions.
We also need to pause here and contrast the two types of visits because their dynamic changes the nurse's approach so dramatically.
You have voluntary visits, which are client-controlled, informal, based on mutual goals. Those are generally easier. Then you have required visits, which are often legally mandated, like follow-up for TB or a court order regarding child safety.
And those are more nurse-controlled.
They are. They have a more formal investigatory tone, and the nurse has to manage that inherent power dynamic very carefully.
The third phase is the longest, the in-home phase. Once you're in, the first few minutes are critical for establishing rapport, that social period, before you state your professional role and determine their expectations.
And this is where the action happens. During this phase, nurses use the intervention wheel, a public health framework, to guide their practice. They're using various interventions like advocacy, case management, health teaching, screening, referral, all based on real-time observations.
And what about managing the chaos? I mean, you're entering someone else's living space. There are interruptions, noise, distractions.
That is a primary practical challenge. The nurse has to politely but assertively manage interruptions. A loud television, a barking dog, kids running around.
The family might not realize how distracting that is. The nurse can gently ask them to turn off the TV or limit disruptive activities, balancing assertiveness with maintaining that crucial rapport.
Phase 4 is the termination phase. This isn't just saying goodbye. It's a systematic review of what happened, what was accomplished, and concrete planning for future visits or, eventually, the planned termination of service.
Which ideally is discussed and planned from the very first contact when you set the goals. And the final phase is the post-visit phase, the critical task of documenting the visit accurately. The common limitation here is that agency records often prioritize the individual chart.
So the community health nurse has to be very intentional about cross-referencing and focusing on the individual within the family structure. The documentation needs to be current, dated, signed, and maintain that critical family focus.
Moving beyond the physical visit, the next major intervention strategy is B, contracting with families. This is a highly formalized, yet continuously renegotiable working agreement.
And the philosophical premise is key. Increased family control leads to increased self-efficacy and ultimately an increased ability to make and sustain healthful choices. It is partnership in action.
And there are two main types of contracts, right?
Yes, a contingency contract clearly states a specific reward the client gets upon completion. A non-contingency contract relies on the implied, intrinsic reward of the positive outcome, feeling better, having lower blood pressure.
And it's essential that the contract involves all responsible family members. Even if you can't get them all in a room at once, every member should review it, give input, and formally agree to sign.
Exactly. The process itself is detailed. It involves 3 phases and 8 activities. The beginning phase involves mutual data collection, mutual goal establishment, which has to be realistic, and mutual plan development.
The working phase then includes 4 activities: mutual division of responsibilities, mutual setting of realistic time limits, mutual implementation, and continuous mutual evaluation and renegotiation.
And finally, the termination phase is just the mutual termination of the contract when the goals are met. Our sources provide an excellent QSEN case study, Mr. Jones, a 78-year-old with a CVA and memory deficits, to illustrate this.
Okay, let's walk through that example. For the beginning phase, the nurse would collect extensive baseline data reviewing therapy plans, Mr. Jones's pre-CVA habits, involving the wife and daughter. The critical part is making sure the goals maintain Mr. Jones's autonomy.
So a realistic mutual goal might be that Mr. Jones will initiate taking his medications daily, maybe with a pre-prepared pill box, but he only requires assistance when needed. That preserves his independence.
For the working phase, the plan would include detailed responsibilities. The nurse might suggest alternative communication strategies, like a dry erase board, and the mutual division of responsibilities would involve the wife and daughter, figuring out if the daughter's monthly visits are enough respite for the wife.
And evaluation is ongoing. The family might track near falls, the success rate of the medication. The nurse checks in weekly to ensure Mr. Jones still feels he has a voice, that the contract isn't accidentally removing his agency.
And termination happens when the family agrees they feel independent and autonomous in managing the ongoing care.
This approach leads directly to our final overarching intervention strategy. C. Empowering families. We have to shift our focus from simple help giving, which can lead to resentment and dependency, to fundamental empowerment.
And empowered families share three characteristics, right?
Yes. They have 1. Access and control over needed resources. 2. Demonstrated decision-making and problem-solving abilities. And 3. The crucial ability to communicate and obtain resources. They know how to negotiate with outside agencies.
So the underlying principles of empowerment are philosophically different from traditional care.
Absolutely. Empowerment sees the nurse-client relationship as a true partnership. It assumes families are competent, or can become competent, and it focuses intensely on their strengths and competencies rather than just their deficits. The goal is shared responsibility.
And we can apply the levels of prevention to these family models. For primary prevention, which aims to prevent disease, we'd use the genogram to assess future health risks and contract for activities that prevent those diseases from developing.
For secondary prevention, which is about early detection, we might use a behavioral risk survey to screen and identify factors leading to a current issue, like childhood obesity, and contract for early diet changes.
And for tertiary prevention, aimed at minimizing complications from a known problem, we'd contract with the family, like the Mr. Jones example, to change nutrition or adhere to medication to reduce further complications. The framework works across all three levels.
As community health nurses, we have to specifically focus on vulnerable populations that face these compounded risks. We can start with LGBTQIA+ families.
Right. Despite the 2015 Supreme Court ruling on same-sex marriage and federal directives on hospital visitation, structural and social barriers are still there. Discrimination is still a real issue.
And we know that sexual and gender minorities face a statistically higher risk for mental health issues, elevated rates of depression, anxiety, substance abuse, and unfortunately suicide. These are direct results of minority stress.
So the nurse's role is crucial here.
Its advocacy is providing culturally competent care that respects diverse family forms, ensuring safe environments for open discussion, and providing targeted referrals to resources like PFLA.
Another extremely vulnerable group is teenage parent families. They face so many compounding challenges: financial instability, social isolation, and just massive difficulties accessing consistent, quality healthcare.
They often need instructional literature geared specifically for teens, not just about baby care, but about welfare, legal issues, available support. And crucially, we have to stress the importance of post-pregnancy support programs.
Why are those post-pregnancy programs so vital?
Because the evidence shows that children of teenage parents often repeat the cycle of poor outcomes, low socioeconomic status, difficult childhoods, becoming teen parents themselves. Adequate family health care and longitudinal support are absolutely essential to breaking that intergenerational cycle.
Whether a family is navigating these challenges or others, the nurse has to be a crucial link to community resources. Families have complex needs that no single professional can solve alone.
The nurse acts as a client advocate to help families navigate this maze of eligibility and service delivery. We need to be familiar with both government resources, Medicare, Medicaid, TANF, WIC, SHE-HEIT, and voluntary resources, like the American Cancer Society or local domestic violence shelters.
Helping them through that process means sharing information, rehearsing what to ask when they call an agency, even arranging transportation.
It does. And a rapidly growing resource that impacts how we deliver this care is telehomecare.
Or telehealth, telemedicine. It involves clients communicating and transferring information like blood pressure or glucose readings to providers from home.
This is highly feasible for frequent monitoring of conditions like CHF, and it's incredibly useful in remote areas. It lets nurses monitor more clients per day without driving for hours.
But there is a crucial caveat that needs to be shouted from the rooftops.
It needs to be. Telehome care is not a substitute for in-home trust. relationship building, and the comprehensive assessment of the family's dynamic and community resources that can only be accomplished by an attentive nurse spending time in the physical home environment.
Technology enhances, but it does not replace.
It does not replace the fundamental human connection and observational skills of the community health nurse.
Finally, let's return to policy. The Family Medical Leave Act, or FMLA, of 1993 is a key national policy supporting families.
FMLA allows covered employees up to 12 weeks of leave each year for serious illness of themselves, a spouse, parent, or child, or for the birth or adoption of a child. And crucially, they still get their medical benefits and are guaranteed their job back.
That sounds fantastic on paper, but if you look at the reality for low-income families, it's a double-edged sword because that leave is generally unpaid.
That is the critical insight. While job protection is vital, the unpaid nature of FMLA creates immense financial stress for low and even middle-income families. It can make the policy a source of stress rather than pure relief.
So the need for paid family leave is an emerging policy issue.
It is, and it reflects a growing societal recognition that the healthy family unit is a key contributor to the overall health of our society. Policy often follows practice, and nurses' observations from their home visits are what drive that policy recognition forward.
That's a great point.
So, to wrap up this deep dive into Chapter 21, let's just crystallize the most important practice takeaways. First, the family is the foundational unit for health behavior and risk reduction. It is the essential target for improving population health.
Second, community health nurses have to master these systems-focused tools, the genogram and the ecomap, to quickly understand the complex interrelationships and the synergistic accumulation of all those risks.
Third, the home visit. It's a signature intervention that provides unique, accurate data that is impossible to get in a clinic setting. It is the ideal venue for assessment and intervention, provided safety protocols are followed.
And fourth, our interventions must always focus on partnership. We have to shift control to the family unit through structured approaches like formal contracting and that philosophical shift toward empowerment, focusing on their strengths, not just their deficits.
Understanding all of this, the complex interplay of resources, environment, policy, genetics, that's what separates a clinician from a true public health nurse.
Here is the final thought we want to leave you with. The health of the nation depends fundamentally on the health of its families. We noted that so many middle-income families fall into that vulnerable economic gap, working but without adequate health benefits, which leaves them perpetually susceptible to crisis. The ongoing challenge for the next generation of public health nurses is not just to intervene in the home with the tools we discussed today, but to continue that tradition of social activism. You have to use the stories and the hard data from your caseloads, the powerful insights from your genograms and ecomaps to advocate tirelessly for policy changes that provide comprehensive, preventative health infrastructure for all families. That advocacy is just as essential as the technical intervention itself.
A truly profound call to action. Thank you for joining us for this deep dive into family health risks.
We appreciate you engaging with the material. We'll catch you on the next deep dive.